Good morning, everybody. Um, Welcome to this Facebook Live event from Boston Children's Hospital about thyroid nodules in children and the importance of multidisciplinary care. My name is Ari Wassner. I'm the medical director of the Boston Children's Thyroid Center.
And I'm Biren Modi. I'm the surgical director of our thyroid center. As Ari mentioned, we'd like to talk about thyroid nodules specifically today. So, Ari, maybe you want to start off by just sort of explaining what thyroid nodules are.
Sure. So thyroid nodule is just kind of a fancy word for a lump in the thyroid. So usually in kids, thyroid nodules are generally picked up often by the child or by a parent who will sort of see a lump in the neck, or maybe the child will feel something when they're swallowing. Sometimes a lump will get picked up by a primary care doctor or another doctor as they do an exam, or occasionally when the child might have imaging for some other reason, they'll pick up a lump in the thyroid. And that usually, the first thing people often wonder is, anytime they find a lump anywhere is, could it be a cancer? So the good news is that we know in children, most thyroid nodules are benign, meaning they're not cancerous. But there is a subset that can be thyroid cancers. About 1 in 4 thyroid nodules in children turn out to be a thyroid cancer. So that's the reason it's important when a child has a thyroid nodule that they be evaluated by experts who know how to do this evaluation and try to figure out, is it one of those subset that might be a thyroid cancer, or is it just a benign nodule?
Yeah, that's a great point. And I guess maybe the corollary to that then is sort of explaining maybe for the folks at home that haven't been through this or don't know, what does that evaluation really look like when they end up finding out that they have a lump in their thyroid?
Yeah. So once there's either a nodule that's found or suspected, the most important thing that we can do is to take a look at it. So we use imaging to look at the nodule and try to figure out what it looks like, because that's going to determine what we do with it. So the best way to look at thyroid nodules is using ultrasound. So for anybody in the audience who's been pregnant, they might have had an ultrasound, which is how we look at babies before they're born. So ultrasound is painless, not invasive, quick, and it gets great images of the thyroid. So that would be done by an expert thyroid radiologist who does an ultrasound and can look at the thyroid and the nodule to tell us about its characteristics. And those characteristics are what tells us how concerned we should be. Is it probably benign, or might there be an abnormality that we need to look into further? So in our clinic, that would be done in our thyroid nodule clinic with a radiologist, a thyroid radiologist, and an endocrinologist like myself. We look together at the images, talk with the patient, and decide, is this something that needs further evaluation? If it does look like it needs further evaluation, the next step might be to do something called a fine needle aspiration or a biopsy. So the fine needle aspiration is kind of the standard of care for how to evaluate suspicious thyroid nodules. And that basically involves us taking a fine needle, a very thin needle, and taking a tiny sample from the nodule. We send it to a lab where an expert pathologist would look at it and tell us something about the cells that came out of it. Do they look normal, like just a benign nodule, or is there some abnormality that might suggest a possible cancer that we might need to address further?
Well, obviously, the sound of sticking a needle in somebody's neck sounds a little scary, probably for our
Yeah,
audience at home. Do you want to maybe walk them through what that looks like? Because you guys have a
yeah.
great success rate at doing that in clinic.
Yeah. So I think it's a fair point. So the idea of a biopsy is definitely, I think, one of a major source of anxiety for parents and for kids, as you can imagine. So I think maybe we can allay some of that. I think it certainly sounds scary, but it actually is. We consider it quite a minor procedure. It takes about 5 minutes or so, and we do it in the clinic, so in our thyroid nodule clinic, where we do the ultrasounds. One of the nice things about how we've been able to do it and learn to do it over time is that we don't have to sedate kids to do it. So a lot of places will put kids to sleep for a thyroid nodule biopsy. We've been doing this for almost 20 years, and we almost never need to put kids to sleep, even as young as 6 or 7 years old. They can do it quite comfortably with a parent by their side, holding their hand, talking to them. So the process, basically, they would typically come to clinic for an evaluation. When we first see them, they would meet with a nurse who will talk to them, get a little bit of history, and put some cream on their neck. And the cream is an anesthetic cream that kind of numbs up the surface of the skin And we do that for everybody who gets an ultrasound, just in case we need to do a biopsy. And then once they've come, they've seen the radiologist and the endocrinologist, we've talked about the images, and we decide, yeah, we do think a biopsy would be helpful. Then we'll use that sort of numbed up neck from the cream to put a little bit of extra anesthetic, local anesthetic, like a Novocaine, like you might get at the dentist, right at that spot where we're going to take the sample. That numbs it up at a little deeper level. And then we can take the sample comfortably. Child can, as I said, can kind of lie there on the bed. Parent can be next to them, hold their hand, talk to them. The radiologist is there with the ultrasound to show us exactly where the nodule is, so that the endocrinologist can pass the needle directly into the nodule, so we get the best sample, and also to avoid any of the other important structures so we don't cause any damage. We usually take about between 3 and 5 samples from each nodule, depending on how it goes. And that's kind of it. We send that to the lab. Once we're done, as I said, it takes less than about 5 minutes. Patient sits up, they get a little tiny Band-Aid on there. They don't have any restrictions. They can eat, drink. I tell them they can go out and play rugby or wrestle or whatever. And that's pretty much it. They walk out the door. Results take about a week to come back. So typically we'll schedule a time to talk about a week later, and then kind of go from there. So that's kind of the process, and we get a result back. And sometimes those need to be dealt with on the surgical side. So I think maybe I'll kick it over to you and just sort of ask you to describe a little bit from a surgeon's perspective, how you decide when a child with a thyroid nodule might need surgery or not.
Yeah. Well, I think of thyroid surgeries being either one or both for diagnosis as an extension of that fine needle aspiration that you're doing, or for therapy, and for therapy for either for cancer, if that's the case, or sometimes for nodules that are large and cause symptoms like difficulty breathing while you're laying flat, or swallowing problems, or sometimes for therapy in the sense that some children have thyroids that have a lot of nodules, where the workup would involve just too many fine needle aspirations, and it's just too difficult to make sure that we're properly caring for all of the nodules in the thyroid. And it makes more sense to undergo the operation. And in those cases, obviously, we have a big discussion about what the risks and benefits are. The more common scenarios that is done for diagnosis as an extension to fine needle aspiration, as you said, it takes about 7 to 10 days for those results to come back when you do a biopsy. And those are sent off to really world-class cytopathologists that we have as part of our multidisciplinary center here. And they classify those cells into a variety of different categories based on a sort of international scoring system. And they can say definitely benign or definitely malignant, meaning cancer, but there are some categories in the middle that are less clear. And often for those categories, we have to take out the nodule to get a better look at it under the microscope, rather than the small sample that you might be able to provide with the fine needle aspiration. And then that can give us a definitive answer. In those cases, just to sort of briefly talk about the anatomy of the thyroid, it looks like a butterfly sitting on your airway. And so when we do it for diagnosis purposes, we're typically just taking out half of the butterfly, so just one wing of the butterfly, and the other wing stays in place. And so if the diagnosis from taking that out is that there's not cancer, that's great news. And the other half of the thyroid typically, in most patients, is enough that they don't ever have to go on thyroid medicine and don't need any additional sort of management from that standpoint, other than potentially some ultrasounds to make sure that they don't develop nodules on the other side. If it comes back as cancer, in most cases for thyroid cancer in children, the entire thyroid gland needs to come out. And so if we know ahead of time before surgery, we take out the whole butterfly. If we don't know, we just do that half a thyroid removal, then we go back in afterwards with the second operation to remove the rest of the thyroid. And the benefit of that is that the primary care for thyroid cancer is actually surgical resection, removing the cancer from the neck and any lymph nodes that may be associated, that may be involved. And secondarily, it helps with the rest of care for thyroid cancer. I think that's the overall sort of goal in my mind, is either diagnostic extension of the FNA or actual therapy to remove the cancer.
Sure, that makes sense. And I guess, as you're talking about this, it sounds like many things that you're doing a pretty delicate surgery, and I would imagine that the experience of the surgeon who's doing it probably makes a big difference.
Yeah, absolutely. That's actually a really important point. It's a topic that I usually discuss at length with patients and their parents. Is one of the ways we've set up our thyroid center very purposefully is to have only two of us in our surgical department who do thyroid operations. And the purpose of that is to concentrate that experience in just the two of us, myself and my partner, Dr. Zendejas. And what we know from looking at thyroid surgery is that the more thyroid operations a surgeon does, the lower the complication rate. And we found, looking at various series and multiple sort of national societies made up of doctors that take care of thyroid cancer, have shown that if you do 15 to 30 thyroid cancer operations a year, you're doing plenty in the sense that your complication rate is low enough that it's acceptable, if you will. We can never get complication rates to zero. That just can't happen. But what we know from looking at our experiences that our volume, the number of operations of thyroid cancer and thyroid surgery that we do is high enough, is well above those numbers, so that our complication rates are very low. In fact, our complication rates rival the complication rates of adult thyroid surgeons who do, many more thyroid cancer operations because it's much more common in adults. But with the benefit of being taken care of at the Boston Children's Hospital, where you have the multidisciplinary care, sort of a more friendly environment for a child taking with a complicated disease and who needs a variety of caretakers. So that volume issue is important. It's something that we have worked to develop here over time. It's one of the reasons we formed this thyroid center, is to really concentrate our experience and make sure that we're providing the best care in a multidisciplinary model. But as I talk about that multidisciplinary model is sort of just one aspect of, or surgery is just one aspect of that multidisciplinary model. What other providers would you say are really key to our center?
I mean, I think, as you say, right, we've already sort of talked about a bunch of the aspects of kind of evaluating and caring for nodules. So as we said, there's a few people who are part of that team. So, there's an endocrinologist who's sort of involved in guiding the initial evaluation, but that's alongside a thyroid radiologist who has expertise in ultrasound. We talked about the pathologist whose expertise is in interpreting those cells that we take out to try to guide our management. Obviously, there are surgeons who need to be involved, you and Dr. Zendejas. And then in the cases where we do diagnose a thyroid cancer, there's a whole other set of folks who may be involved, like nuclear medicine specialists, occasionally oncologists, mental health and social work, nursing. So there's a whole nutrition. So there's a whole team of people who I think are really closely involved in caring for kids with thyroid nodules and thyroid cancer, if it comes to that. And I think, it's really the marriage of two kind of sets of expertise. There's the expertise in thyroid nodules and thyroid cancer, which is medical. And then there's the expertise in working with kids, which is another huge important piece. And I think having a team in the thyroid center, as we do, that does that all speaks the same language and can really kind of work cohesively to take care of kids in this situation is really critical. And so it's one of the things I'm really proud of in the thyroid center that we've built over the last 20 years or so.
Yeah, I think that's a great point. I guess maybe we should stop this part and move on to some questions that maybe the audience has. It looks like there are some questions that have come in while we were talking.
Mm-hmm.
Why don't we start with this one? What, if you can tell us, what causes thyroid nodules? Is there anything that patients can do to get them or not do to get them?
Yeah, no, I think that's probably one of the most common questions that we get when kids come in with thyroid nodules. And we always, it's a natural question, right? Like, why did this happen to me or my child? Unfortunately, we don't have a very satisfying answer to that question. In most cases, the answer is we don't know. So most thyroid nodules are what we call sporadic, meaning they just kind of happen for no apparent reason. That's true in adults too. And we don't know why some people develop them as kids. So it's in some ways a little bit of a black box. It's on the research side, that is what's one of the things that we study in the thyroid center is trying to learn about why that happens. But in most cases, there's no known cause. I will say that in rare cases, there are some underlying genetic conditions that are rare, but they can cause thyroid nodules to develop often those kids develop multiple thyroid nodules.
Right.
And so in the cases where we see kids, especially very young kids who develop multiple nodules, we think about those potential genetic causes, and we have ways of testing for those things if it's relevant. But in most people, most kids who show up with a nodule, unfortunately, we almost never get a real explanation for why that happens.
Yeah.
Let's see if there's another question that came up. I think, oh, here. So one is just sort of more a general question about kind of thyroid surgery and kind of what that experience is like for kids if they do need to go to surgery. Kind of how would you just sort of describe that to people? Kind of the
Yeah.
process of going through surgery.
Yeah. I think the most important thing that kids hear is that they will be totally asleep during the operation. So the operation is typically done, well, it's always done here at our Longwood campus in our main hospital. It typically is a overnight stay. So the child would come in the day of surgery and see me or my partner in pre-op. We talk about the operation, which we would have already done in clinic, obviously, and we just give a chance to ask any other questions that may come up. And they would also meet the nursing team from the OR and the anesthesia doctors that would help them go off to sleep. And then they would go back to the OR and they would be totally asleep during the whole thing. The operation takes anywhere from 2 to 4 hours, depending on what kind of operation we're doing. If we're just taking out that half of the butterfly, or if we're taking out the whole butterfly or any lymph nodes. And then afterwards, they recover. We typically keep patients overnight for one night for monitoring purposes, to both make sure they don't have any swelling that affects problems with breathing. And also if we've taken out the whole thyroid gland and we're worried about these other glands that sit behind the thyroid gland called the parathyroid glands, they control calcium levels in our body, and we want to make sure that those are functioning properly after surgery because they can get irritated from being sort of manipulated in the operating room. And so we sometimes will check calcium levels, and in patients who get a total thyroidectomy, the whole butterfly is removed, we actually automatically give them calcium and a very strong form of calcium, vitamin D, and we go over the details of that. And then typically patients can go home the following day. The thing that kids complain about the most after the operation actually is not the incision, which is pretty small and doesn't hurt too much. And we hide that sort of in the skin creases of their neck. It's more that they have a sore throat, because when I'm operating on the thyroid, I'm operating sort of on the airway from the outside. And during the operation, they have a breathing tube in. So there's a breathing tube that's affecting the airway on the inside. So they get a lot of airway inflammation. Most of the kids I've talked to about it sort of describe it as the worst strep throat, that they've ever had. But it goes away very quickly. And the good news is, simple therapy like ice and ibuprofen typically do the job in terms of pain control. There's really not any activity restrictions after this operation. Kids can go straight back to doing whatever they want. They might be out of school for a few days just from being tired from the operation and from the anesthesia. But the recovery otherwise is really swift. For older children, I ask them not to drive until their neck feels normal. But that's, that takes a week or two. Yeah.
That's great.
Um,
Thanks for running
yeah.
through that.
There are other, let me see if it looks like there's some other questions
so
in the chat.
So there's a question here that I think that we get a lot. So maybe we'll sort of I can talk about this one. So the question is, if a parent has multiple nodules and or has thyroid cancer, is there a risk to the children for developing nodules and or cancer? I think that's also another very common question. So in general, thyroid cancer is not familial. Okay. So thyroid cancer in adults is actually quite common. It's one of the most common cancers in adults, especially in women. And so, having one relative, for example, one parent who develops thyroid cancer as an adult, in general, is not a risk factor for kids to develop nodules or cancer. There are rare, as I mentioned earlier, there are some rare genetic conditions that can run in families and can predispose to thyroid nodules or cancer. Those are rare, but they can happen. And so I think particularly if there's a strong family history, not just one parent, but parent and a grandparent and or multiple other relatives, or if the child is very young, if there's a child who's very young or has multiple nodules, we might think about one of those rarer conditions. But absent that, in general, if it's one adult relative who has a thyroid cancer that developed as an adult, generally that's not a risk factor for thyroid cancer or nodules in kids, and we don't typically recommend screening for those children. other than just kind of normal well care, their pediatrician should obviously examine their thyroid as part of their well care. And if they feel something, then that would be a reason to think about doing an ultrasound.
Yeah, I think maybe part of that also is, our group, part of our multidisciplinary group is that we do have cancer genetics
Yeah.
folks that are interested in thyroid cancer and specifically in thyroid nodules. And so when patients do sort of meet those kind of criteria that you were talking about, we'll often have them consult with our genetics experts to look into that potential.
Yeah.
There's another question here, Ari, that I think might be good for you. Does an enlarged goiter by itself, a large thyroid gland,
Mm.
require an FNA test?
Yeah. So yes, that's a good question. So goiter, this often comes up. So the term goiter, for those who haven't heard it, just basically means a big thyroid. So a goiter is, and sometimes it's big enough to actually see. Sometimes it's just big enough to feel, but goiter just means a big thyroid. So I would separate that a little bit from a nodule. So a goiter can be just a diffuse enlargement, and that can happen for a bunch of reasons. Probably the most common is something called autoimmune thyroiditis or Hashimoto disease, which is very common, particularly in adolescent and adult women. That can cause enlargement, but it doesn't necessarily cause nodules. So when we're talking about doing biopsies or fine needle aspirations, that's something we would do for a discrete nodule. So a discrete lump that's there, might be growing. Those are the ones that we start to think about the possibility of a thyroid cancer. Just because a thyroid is big doesn't necessarily mean it needs a biopsy unless there's a discrete nodule. And I will say that sometimes deciding whether there's a discrete nodule is not always so straightforward. It can be tricky, especially in people who have Hashimoto's. And so you really need a thyroid ultrasound radiologist who's expert in and has a lot of experience looking at thyroids, particularly in kids, to be able to say, is this really a nodule or is it not? And frankly, a lot of the kids that we see are referred for suspected nodules, but actually when an expert looks with an ultrasound, they say, actually, you know what, it's not really a nodule. We don't need to go down the road of FNA. And that's really a useful part of the expertise that we can offer.
Yeah, and I think maybe a corollary to that, somebody also asked, is there an increased risk of thyroid nodules or thyroid cancer in cases like goiter or hyperthyroidism if somebody has a scenario where their thyroid
Yeah.
is taking over time?
Yeah, so that's a complicated question. So I would say, broadly speaking, goiter, so big thyroid overall, is I'm not sure that we know that that is associated with thyroid cancer per se. There is, I would say, quite a vigorous debate about whether autoimmune thyroid disease, Hashimoto's, is associated with thyroid cancer. And I would say I'm not sure we know the exact answer to that, whether autoimmune thyroid disease increases the risk of thyroid cancer. Um, Hyperthyroidism is a little bit of a different story, and there's a few different causes of hyperthyroidism. Occasionally, you can have nodules, actual thyroid nodules that are overactive that cause hyperthyroidism. Those type of nodules, which we call autonomous nodules or toxic nodules, those are almost never cancer. And so those nodules, if we can prove that that's what they are, we don't even biopsy them because they're essentially never cancer.
Yeah.
More common cause of hyperthyroidism would be something called Graves' disease. That is a form of autoimmune thyroid disease, kind of like Hashimoto's. And I would say that falls in under the similar category. That is, there is some suggestion that there may be an increased risk of thyroid cancer in those patients, but it's not totally clear. And so those patients, I would say clinically, we manage them with careful exams. And if we feel asymmetry, one side of the gland is much bigger than the other, or if we feel a lump, then I would say it's time to move on to an ultrasound and make sure. But we don't necessarily do ultrasounds in everybody who has hyperthyroidism or everybody who has Hashimoto's, because that's probably overkill and not necessary if we're doing careful exams.
Right.
Does that
And
make sense?
there's another question that came up, which I think is a really interesting one and important for us to talk about is what is the transition of care as the child ages out of pediatric care and into adult care, and
Yeah.
specifically children who had thyroid cancer, who had their thyroid removed, had their lymph nodes removed, had radioactive iodine treatment. How do they transition to being monitored for that as adults? And I think, again, this speaks to sort of the benefit of our multidisciplinary group here.
Yeah, no, for sure. So I think, and this gets a little bit to the issues about transition of care in general for pediatric patients. So anyone who has a chronic disease as a child has to, at some point, move over to adult care. So I think, one of the benefits for thyroid disease, and particularly thyroid cancer, is that thyroid cancer is actually far more common in adults than it is in kids. So we see a lot of thyroid cancer in kids because that's what we do. But in adult endocrinology and surgery, thyroid cancer is much more common. So there are many more adult providers who are skilled at taking care of thyroid cancer than there are in pediatrics, where you really need a big center. We are fortunate in that, our patients, at least those who stick around the area, we have a very close relationship with Brigham and Women's, which is our adult sister hospital across the street. And in fact, we share our thyroid ultrasound and thyroid cytopathology because they are an adult hospital. They see thousands of thyroid nodules a year, which no pediatric hospital can. And so we're able to, by partnering with them, our pediatric patients can benefit from their enormous expertise in thyroid ultrasound, thyroid cytology, to provide the best care for our pediatric patients. And that also is applicable when we transition, so that we can then, when they become adults, we can send them over to the Brigham and Women's Hospital, to our adult thyroid colleagues who we work with closely, and they are still seeing the same ultrasonographer, the same cytopathologist if they need it. So that really can be a pretty seamless transition from a pediatric thyroid center to a world-class adult thyroid center. So that's something we do for folks who stay in the area. Obviously, if they move elsewhere, we can help connect people to thyroid specialists or thyroid cancer physicians in other places.
Yeah. I think we're starting to run out of time, so maybe I'll just take a moment to mention that as we're on the topic of thyroid cancer, we are planning on doing an additional webinar probably next month, where we'll talk more specifically about thyroid cancer and treatment of thyroid cancer, both surgical and medical, as well as sort of the post-operative management and ongoing care of thyroid cancer. So if you're interested in that, please be on the lookout on our Facebook page, and also through our Thyroid Center page and our outreach from Children's. If we didn't get to your question today, or if you have additional questions, please feel free to reach out to us. Our website is bostonchildrens.org/thyroid. And on there is our contact information. You can also call us at 617-355-8226.
Thanks everybody for coming today, and hope they'll be in touch with you if need be, and have a great day.
Thank you, everybody.